to get us started? What's up? I'm going to introduce you. Yeah. Hi, and thank you for joining us for Primary Care for America's deep dive into the 2026 Medicare Physician Fee Schedule Final Rule impacts on primary care. I want to first thank our Primary Care for America partners and collaborators. Primary Care for America advocates in partnership with innovative primary care organizations united in our goals to provide high quality, comprehensive, and accessible primary care to all patients. My name is Sean Martin, and I'm pleased to be here today on behalf of Primary Care for America. My day job, I am CEO of the American Academy of Family Physicians. This event is being live streamed across the country, but we also will make a recording available on our website in about one day. Now, let's get started with our program. It's my pleasure to moderate this first panel with the CMS Medicare team, starting with Chris Klump, Director of Medicare and Deputy Administrator at the Centers for Medicare and Medicaid Services. Alec Aramonda, Principal Deputy Director, Center for Medicare, and Joe Albanese, Director of Policy at the Center for Medicare. Thank you guys so much for being with us today. So let me start with just congratulating you on getting a fee schedule out in the midst of your first year. I mean, it's no easy feat to meet a deadline and get a fee schedule out, and I just want to congratulate you on that. I also, it's a chef's kiss to do that on Halloween. I thought that was really nice.
It was like 5:10
yes.
on Halloween.
We can talk about whether it was trick or treat. We can get into that, as we work through.
Definitely treats. There's no question.
So let's jump in. So for the first time in 6 years, the fee schedule final rule has included an increase in the conversion factor for physicians. There's the statutory requirement that came out of OB3, and then for the first time, there is the mandatory updates for both the fee-for-service program and also for the advanced alternative payment model. So I would love to just kind of start off by just talking a little bit about how you're thinking about the rule and level setting and the fact that the conversion factor is going to provide increases to physicians regardless of their practice type across the country.
Please.
Joe, you want to?
Sure. So as you mentioned, we are implementing some of the language of OB3 that's going to be benefiting physicians across the board in the PFS. It's also an important year because we're going to be implementing for the first time the split conversion factor from MACRA. That's going to be important, especially for clinicians that are choosing between participation in an advanced APM versus staying in MIPS. So as time goes on, this is going to be a compounding factor that's going to make it even more important to consider options for APM participation. And that's going to be part of the overall shift away from the fee-for-service paradigm into a more value-based one. But especially some of the changes that we had implemented regarding the efficiency adjustment, which we'll go into in a little bit. That is something that we think is especially helpful for primary care physicians because it's going to be taking into account some of the innovations that happen over time across different procedures. But it's going to especially emphasize the importance of the time that doctors spend with their patients in E&M visits and all kinds of other important interactions that are going to be helpful for driving that relationship with the primary care practitioner, and hopefully it'll emphasize the importance of that relationship throughout the fee schedule and in the Medicare program. I'm not sure if you guys have anything else.
I would just briefly, Joe summed it up very well. I would briefly add that part of the impetus behind the rule, more broadly speaking, was an emphasis on accuracy in the PFS, and I think hopefully one of the lessons going forward is that by focusing in on more empirically derived payment and things like the efficiency adjustment, there's actually a corresponding benefit to the kind of the broader system. So I think it'll hopefully create more room for us to consider additional policies to enhance accuracy.
Yeah, in addition to payment accuracy, I'd simply emphasize you'll see this as a recurring theme from us, and we try to focus on principles in order to guide rules, as opposed to starting with rules and backing into principles. What are the principles here? We care about primary care. We want to drive participation in alternative payment models. We want to drive participation into preventive care, and so you'll see that as a recurring theme, not just in this rule, but ongoing.
That's great. So you guys kind of moved us into beyond the conversion factor into some things. So if we can, the administration you guys are clearly pursuing significant structural changes to how you think about payment under the Medicare fee schedule. Policies like the efficiency adjustment, practice expense methodology are going to have an immediate impact on January 1 on primary care and others physicians. So can we dig a little deeper into kind of those two things, the thinking behind both of those policies, not just how you came to pursue them on January 1, 2026, but how you're thinking about them in, let's say, the short horizon of 3 years moving forward.
I can just start on the, I know Joe covered some of the efficiency adjustment, but maybe one starting point on practice expenses more generally is this idea that, you look at across not just the fee schedule, but I know it's in a proposed rule format now, but the outpatient prospective payment system and other CMS broader initiative to make sure that allowing for providers to compete based off of the value that they deliver for their patients and being as neutral as can be on where that particular service is delivered, and also taking into account basically the transformation in medical practices over decades when this policy was initially, or kind of the initial understanding of practice expense was in place. A lot has changed since then, so I think reflecting that we want to create a bulwark for physicians who are practicing in their communities, that they can continue to do so, and whether that be in an independent practice setting, or if it makes sense for them in a facility setting, that's also, we want to encourage that as well, but not to tip our fingers on the scales to harm community practices.
Mm-hmm.
That's right. I think the point I would add as well is simply, broadly we're trying to modernize our payment systems, and we're trying to drive toward value, as has been mentioned. We believe in accountability. Accountability can be manifest in myriad ways. Right? You could take subcap or global cap under Medicare Advantage. You could participate in an accountable care organization. Sometimes accountability comes as an independent practitioner. We want to make sure that we're not discouraging that, but we're supporting independent clinicians. And so making adjustments to the practice expense in particular to make sure that in effect we aren't almost double paying, as has happened, as we've seen acquisitions of independent clinics by facilities, was something that we wanted to make sure. Not because we're trying to make a commentary against health systems and employed practitioners at all, but really want to emphasize Alex's point. Simply, we don't want to put our finger on the scale.
Yeah, and I think just to put a fine point as well on the fact that we're modernizing our payment systems, there's a lot of attention, I think rightfully so, on the different alternative payment models, MSSP, the models that are within MA, but even within the traditional Medicare program, we're trying to make changes that are going to reflect the changes in the practice of medicine, as Alec mentioned, that have happened over the years and haven't always been reflected in policy.
Yeah. So I'm hearing you guys say, just to kind of summarize, you're still committed to alternative payment models, the broad principles, using the fee schedule to drive value in a variety of ways, not necessarily just in a particular one model over another, but really trying to create that equity of opportunity and the value movement across a variety of practice settings. Is that
That's right.
a fair statement? Okay. So while we're on the topic of improving payment and kind of modernizing the fee schedule, both the proposed rule and the final rule discuss your desire to collect and utilize more data sources, and I believe the way you guys phrased it is empiric, verifiable data sources that allow you to better understand physician services and delivery of physician services. Can you guys kind of dig a little deeper into that, of just kind of what those words mean to you? What kind of data sources are you looking for? Ultimately, I assume there'll be a process for somebody to give you those data sources. Let's dig into that a little bit if you guys are willing.
Yeah, maybe I can again start with the principles without making a commentary in this particular response on fee-for-service versus MA, we do seek accuracy in payment. And if you think about how payment schedules have been set historically, they're largely survey-based. We understand that physicians are very busy. They're busy running their practices. They're busy engaged in rendering care. And yet we're sitting and saying, hey, go ahead and participate, send us a survey, do all this extra paperwork. And what we saw is that across certain specialties, you might have as few as 20 practices responding to a survey, and then we're basing an entire specialty's worth of reimbursement on this very, very statistically insignificant small sample size. Meanwhile, we have other data sources at our disposal, in-market, time-based survey studies, cost studies, and otherwise. There's no reason at this point that we can't incorporate those data sources into our methodologies to more accurately pay. It's a budget neutral fee schedule. The goal is truth. The goal is rooting ourselves in data and evidence first, and then applying policy on top of that. If we're trying to drive emphasis toward primary care or preventive care, great. But let's first understand simply, where are the costs? How much time does it take to render a service? And that's really all that this policy is meant to do. I think it's a first step. I think there are other steps that we can take. But I think it's an important signaling mechanism. Guys, I don't know if you'd add anything to that.
And I would just say that on that last point on the signaling, I think I see it in some ways as an invitation that, not to criticize, I think, the low response surveys, and if there's even maybe some conflicts of interest perhaps inherent in those, but to, I think, open the door, crack the door, so whether it be providers or other third parties to take a closer look, and that we absolutely value that feedback to make decisions for more accurate payment.
Definitely.
So let me,
Hey, Sean, really fast, actually, one more that I would
Yeah.
add to that, and something that we're working on. We've talked about this publicly as well, but part of accurate payment is the policies that govern the schedules. The other part of accurate payment is how we actually adjudicate the claims. I think it's clear that to everyone, we've talked about this, that right now we process about $1.5 billion of claims a day in original Medicare fee-for-service on circa 1970s era COBOL code. I don't know about you, and if anyone here knows how to program in COBOL, but there aren't many left. And those systems are large monolithic systems that are largely black box. They're slow to adapt. They struggle to adapt to innovative payment mechanisms. They struggle to adapt and provide transparency as to what we're seeing in the claims themselves. That would also be an important feedback signal to us to understand true cost, to true time on behalf of our beneficiaries. They also make it difficult for us to understand trending in a timely manner, to understand utilization patterns by region, by practice type, by specialty type, and otherwise, so that we can be more accurate, more responsive in our policy making. So as an agency, and the administrator's been very clear about this publicly, we are deeply committed to driving a modernization of our underlying infrastructure. This has been attempted in the past. There's been a dearth of capability internally in order to do this. We've been bringing technical expertise in. Fun fact, the administrators talked about this, there were 9 engineers in the entirety of CMS when we began in January. The $1.7 trillion program, 9 technical engineers. So we know we have to do better. Part of that is then so that we can modernize these payment systems. So we're trying to deal with it on the front end. We're trying to deal with it on the back end. So we have reconciliation. We have an accurate feedback mechanism, which we believe will then provide more data back to the front end in a positive recursive function.
yeah, on the data sources, how are you thinking philosophically if you see variations by region, for instance, rural physicians versus maybe community health centers isn't a great example because they have a different cost structure, but rural versus urban versus other things, like do you anticipate that will happen, and do you anticipate that you'll have greater clarity on how to potentially regulate around those variances, or just?
I think maybe to start with that, that's part of the reason why we're starting small. We're only picking a few different services of radiation therapy and remote monitoring services. And we hope to expand from there with a lot of feedback and good advice and comments from the public and from stakeholders to see how best we can effectuate that. But I think broadly speaking, when we're looking at payment accuracy and modernizing our payment systems, in urban and rural areas alike, there is a dynamic where payment can help drive the supply. Not to get too wonky with economics here, but the undersupply of primary care or other high-value services that might be effectuated by current payment policy. The idea is to try and make these payments more accurate so that we can make sure that by paying for value, we're increasing the signal to the healthcare system that value is what patients need, and we want to help effectuate that with more accurate data. So I think that's the goal, and we understand that we don't want to be too disruptive, but we're taking some steps to make sure that we understand what the implications are in services where that makes the most sense, and continuing to evaluate and tweak that as we go through future payment rules.
Okay. Let's move to the advanced primary care management codes. Really welcomed addition last year in the primary care community. I think still a lot of enthusiasm based upon the changes you're making, but you guys recommended a couple of integrations of care coordination and behavioral health integration into the APCM. I would love for you guys to talk a little bit about the philosophy behind that, and then I'm going to bring up probably the most controversial thing I'll ask you about is the cost sharing is always, a barrier to entry for some of these innovations on the fee-for-service side. I would, if I could, just grant you authority to just get rid of cost sharing for the APCM. I don't think that's going to get you very far legally, but
Joe, you know, granted. You're here first.
how do we, two-part question, like the integration of services and how you're thinking about the code, and then how do we start to think about what is really a barrier to utilization oftentimes in the cost sharing requirements for some of these innovations in the fee schedule?
I can start and just briefly note, I think when we came in, I think we recognized some of the great work that was done to kind of build out the chassis for the APCM, and that I think we've heard some really, I think, positive feedback to work within that confines and to build it out a little bit more. So I think there's a little bit of, if I pardon the crude term, but just like trial and error, like see what's working. We understand that for some of the, whether they be add-on codes or APCM in general, that take up may not be as robust as maybe some folks that had initially hoped. But what is it that's kind of, is it a burden issue? Is it a lack of more education, more outreach? What are the kind of maybe impediments to greater take up? And I think as we start to build this policy out, I think we're really looking forward to that feedback. So all to say, I think it's see kind of as a starting point to build out kind of a more broader idea for how to bundle and consider codes together.
Yeah, well, thank you for that. A lot of what we've talked about, a lot of what you put in the rule, and a lot of the work that you're doing really is kind of aligning with the Secretary's, initiatives around making America healthy again, and thinking in those contexts of chronic disease and other efforts focused on health and the promulgation of health. Chronic disease is a big issue. So, we know you had the MAHA Summit this week. That's a cumulative event. You work on this every day. But can you speak a little more about how those efforts and those programs are lining up with primary care, how you're thinking about primary care lining up with those efforts, and all the people watching in the primary care community, how they should be orienting themselves around both the efforts on chronic disease, but also the broader Making America Healthy Again initiatives.
Yeah, I'm happy to jump into that. So obviously the Secretary has issued a challenge across the entire department consistent with the Make America Healthy Again initiative to go after root causes of lack of health. As a country, we've made it very easy to be unhealthy and rather difficult to be healthy. Much of that starts with chronic disease, which affects more than 60% of Americans, polychronic 40%, diabetic, emergent diabetic 30%. And so we take seriously this challenge, and we know as payer, we have a bolus of resources that we can apply toward trying to make changes in this regard. I'd mention a couple. One, we've already talked about primary care and a drive toward prevention. What do we mean by that? So quality measures, for example, we spend many tens of billions of dollars on quality measures broadly. Many of those are process measures that are difficult to tie to improvements in health outcomes, and yet it is a quality program. The measures that we think about as directly preventative in nature are, in our estimation at best, early detection, things like breast cancer or colorectal. They're important, but again, they're not moving upstream. So we're starting to ask questions. Should we be making investments 25 years earlier as Medicare before someone joins our program at 65? When they join us, we'll have them for 17.8 years on average. That's not a foregone conclusion, by the way, that we can't make real differences in their lives based on changes, including reversal of chronic disease. I mentioned one yesterday to a group We're thinking about loneliness. That's an interesting one to bring up as we think about chronic disease, but the data is very clear. If you think about social isolation or loneliness in individuals over the age of 65, that correlates to a 30% increase in mortality. That's the same as smoking 15 cigarettes a day or being obese and having a BMI greater than 30. That's enormous.
Yeah.
You want to translate that to dollars, we're spending probably $8 billion a year in direct medical costs as Medicare as a result. That's a problem, that's an epidemic. There's something that we can do about that. So when we go back to the rules as we think about policy, then we think about, well, who is best positioned to make a difference? Well, churches and family can do a lot with that. And there are probably some things, that can be done to help encourage that. Beyond that, who else? Well, providers, primary care providers. But we can have a broader definition of what primary care means. It can be the principal provider, broadly, that you interact with most frequently, and then incentivizing them through quality metrics, other incentives to spend time, to have the resources to spend time to address this underlying root issue. That itself then catalyzes a triggering effect into other chronic disease. Obesity would be another example, 40% obesity rate in the United States. That's correlated with 50% of chronic disease. We spend $1.25 trillion as a country out of our $5 trillion of spend on that, in addition to $300 billion of direct medical cost. So these are the things we're focusing on. And when you see this pop up in our rulemaking, this is what's going on in our minds. These are the questions we're pressing because of the Secretary's admonition. Guys, I don't know from a tactical policy perspective, anything you'd add to that?
No, I would just briefly just echo that one of the things I excited when I hear, the Secretary and then Dr. Oz speaking about this concept of, where you talk about the convergence of primary care with Make America Healthy Again, but also this concept of this principle of subsidiarity, that decisions being made at the most local level, and understanding, where the importance of primary care in that when it comes to, integrating with family and the communities, churches, and so it's a physical, mental, spiritual health all together. I think that gets at a lot of the root causes. So that's an invaluable service that I think we're trying to, in our rulemaking and otherwise, trying to recognize with payment policy.
Yeah, I think we're doing mechanistic things to try and help. We're trying to get RFIs across the board on new concept for quality measures, as Chris mentioned, for wellness and nutrition. We've been updating some of our coding so that there could be greater recognition of payment in the payment policy about screening for nutrition and lifestyle health. But I think that's all going to be downstream of these bigger structural wellness issues that Alec and Chris articulated.
Well, that's great. And I know the primary care community looks forward to supporting those goals. And I was going to ask you a big, raw closing moment question, but I didn't get through my questions fast enough. So I want to ask about telehealth, because I know a lot of people that are watching we opened the government again last night. There was some uneven application of payment for telehealth services over the last 50-ish days. And I'm really thankful that we're going to start paying for those services again, not just for rural communities, but just so the connectivity with primary care is become more dependent on telehealth. But I'm kind of, as we move forward now, obviously Congress could help you guys out a little bit, but how are you thinking about telehealth? How are you thinking about it as a, modality in primary care, but also how are you thinking about it in loneliness and, the other types of things that you've talked about? So strategies around the modalities, and then kind of how you're going to pay for that or incorporate it in the broader efforts that you've spoken to today.
So if you go back to the original COVID-era telehealth expansions, the big concern was, well, this will be abused. It'll be overutilized. We need to make people come to their provider in a brick and mortar in order to control utilization. And so we had a bit of an experiment with that, right, over the course of roughly 5 years. And guys, jump in, correct me if I'm wrong. I think that the data didn't bear out that we saw rampant overutilization or abuse of that. And so the guiding principle here, which is, by the way, not surprising, the guiding principle is we want to meet our beneficiaries where they are, and we want to serve them however they want and need to be served. And we want to make it easy for providers to maintain that relationship however they can best render care. And we don't want the government to be in the business of telling providers how to deliver care and what medical decisions they should be making for their patients. That's not our role. And so what you've seen is, first, with the reopening of the government, yes, we were already trying to pay as many telehealth claims as we could under the statutory provisions without the extenders. Now we're free under the CR through January to be able to pay everything again, and we are immediately putting that into motion. But now you've seen in the rules expansion from a frequency and a reduction of limitations and giving us more flexibility to add services. You guys, if you want to talk about any of the specifics, but that's the principle that this is rooted in.
Yeah, I mean, some of the direction has to come from Congress, but we've done what we can to try to facilitate new services on the telehealth list, make sure that we are working through the fullest flexibilities that we can. So it's good to have some more stability and some more clarity about in the near future what we can be doing with those telehealth claims and how we can try to effectuate better patient-doctor relationships within that framework.
Awesome. Thank you guys so much for joining us here at Primary Care for America for this deep dive. I know I speak for all the primary care community and physicians and clinicians across the country. We're appreciative of the signals that you made in the fee schedule to better support primary care. I think we look forward to building on that and working with you to create a usual source of care, usual source of primary care for all Americans. And thank you so much for joining me here today and us for this conversation.
Thanks.
Thank you.
Thank you.
Appreciate it. Thanks, everyone.
Good afternoon. I am Stephanie Quinn. I am the Senior Vice President of External Affairs and Practice Experience at the American Academy of Family Physicians. Not in my lifetime did I think there would ever be a time where I would say the words Medicare physician fee schedule and exciting in the same sentence, but here we are. We heard a lot of good nuggets and themes that I think were surfaced in the last fee schedule, specifically around accuracy and fairness and whole health. And so we're going to do our best in the next few minutes to surface some of the themes and the nuggets from the 2,400 pages or so. And I have an all-star panel here with me today to dive right in. So what I'd like to do is for everyone to introduce themselves and maybe talk a little bit about your day job and what are the things that jumped off those pages to you. So I'll turn first to my colleague, Kate, that works with me at the AAFP. Kate?
Yeah, thanks, Stephanie. Kate Gillard, Senior Manager of Federal Policy and Regulatory Affairs at AAFP. So my day-to-day job is reading 2,400-page rules and writing comment letters about them. So the big thing that is jumping out to me from the fee schedule in terms of like what's going to have the biggest impact on January 1st, 2026, payment for primary care is going up. It's going up because of the conversion factor and what we saw in HR1, MACRA, a positive budget neutrality adjustment, if you can believe it or not, and then also some of the structural changes that the CMS panel talked about with the efficiency adjustment, practice expense methodology. All of these are working in concert to have a really significant increase to payment for primary care. I was looking at some addenda files this morning that shows something like 58% of family physicians are going to see an increase in their RVUs between 5 and 10%. And like, that's just their RVUs. So you want to talk about an impact in day one. I think it's just dollars and cents.
Thank you. I would agree with that. Kate, what about you?
Katie Boyer, Senior Director of Policy and Government Affairs at Agilon Health. Agilon Health is a value-based care company that partners with largely independent primary care providers across the country, right now in 12 states. And we're largely focused on the full risk end of the value-based care spectrum. So thinking a lot about Medicare Advantage, ACO REACH, and ways that the fee schedule supports providers who are in value. We're really focused on the Medicare program. But we know that the fee schedule also directs a lot of the payment policy in other lines of business. And so I would sort of echo what Kate has said, that the positive adjustment for the conversion factor not only is great for our providers in their Medicare practice, but also drives commercial rates as well. And most of our partners have large books of business in the commercial space. Their ability to perform well and to remain viable in a value-based care model in the Medicare program is also predicated on their ability to remain viable in general, which means that payment policies across the spectrum, their full lines of business, really important. I was also really struck by the 3 pillars that Chris Klomp called out, being primary care, APMs, and prevention. We care about all those things too. And signals are really important to primary care providers, particularly those who are in value. We're always looking forward. We'll talk more about what the needs of signals for the future means, but that stability, that predictability, and understanding where CMS is headed is very, very valuable for primary care providers in the Medicare program and in healthcare in general. So I'll stop there and maybe hold my comments for later, but pass it to you, Mara.
Yeah, Mara?
Hi everybody, Mara McDermott with Accountable for Health. Accountable for Health is an advocacy and policy organization based in DC. I'm fortunate enough to sit between 2 of our member companies, Agilon and Aledade. We do a lot of work in advancing payment delivery models for primary care, specialty care, and technology. So really excited to be with you all today. Our number 1, which I know we're going to talk a lot more about in depth, and didn't come up in the previous panel, is the payment change on skin substitutes. We've seen massive disruption to accountable care organizations and other organizations that are risk-bearing in traditional Medicare around the utilization of skin substitutes, going to total over $15 billion in spend in 2025. So we've got lots of good news there coming out of the rule and more work to do. And I would just say, maybe to build on the other panelists' comments, I was sitting here thinking, 6 months ago feels like 6 years ago, first of all. We didn't know where this administration was going to go on primary care or Medicare Shared Savings Program, ACOs in general, alternative payment models. And I think in many ways this rule came as such a sigh of relief that we're staying the course on all of those things and really looking for ways to improve stability, transparency, and efficiency in those models. And so we were very encouraged by the rule for those reasons as well.
What about you, Sean?
So I'm Sean Cavanaugh. I'm the Chief Policy Officer at Aledade. Aledade is also a value-based care company. We work with independent practices and community health centers in 46 states across the country to help them succeed in value-based care. So we're the largest participant in the Medicare Shared Savings Program, but we help our practices in value-based care and Medicare Advantage and commercial, and even occasionally in Medicaid as well. So my job is to follow what goes on in Washington, dealing with primary care, value-based care. Anything that matters to our practices matters to Aledade. And to respond to the question, we'll get into the details of what's in the regulation as the prior panel did, but stepping back a little, I was thinking more of the context, which is, first of all, Chris Klomp, who was in this seat earlier, he only took over the Center for Medicare in April of this year, and the proposed regulation went out about 90 days later. So usually, because of that situation, the beginning of an administration, you often don't see big policy proposals. And so I was very pleasantly surprised that they were able to hit the ground running, do meaningful work, and send meaningful signals in such a short period of time. And the signals they sent are just as important, which is, our country, through market forces, but unfortunately, also fostered by public policy, has undermined community-based primary care over the past 20 to 30 years. And much of it has been inadvertent. But to reverse that, we're going to have to be very purposeful, and there's a lot of hard work to be done. And I think this regulation makes a real down payment into reversing that through the efficiency adjustment, which we'll talk more about, but also for signaling the efficiency adjustment is just the beginning of that work, that they're going to look to other sources of data as they value fee schedule codes. Where they didn't do a lot of work, but did a lot of signals, was in accountable care. So we're very hopeful, and as they said on the prior panel, that next year's rule will have a significant investment in accountable care as well. So I think given the limited time they had, it was an amazing body of work, and looking forward to working with them next year to do even more.
Yeah, so going back to the efficiency adjustment, we know one of the challenges in primary care is the budget neutrality, shifting of resources. There really isn't a way to increase value of a lot of those services. And so how does the efficiency adjustment help us get there? And how do you all think about that in terms of how that's going to help on our trajectory to move people toward value? Does anyone have any comments on that?
Well, having been at CMS in a prior life, you're right, the challenge is the budget neutrality of the fee schedule. But it's interesting, that becomes most problematic when we're trying to help primary care. So we just spent 20 or 30 years, actually, you could almost go back to when the fee schedule was first created in '93, which did shift a lot of money to cognitive services, primary care, and almost immediately after implementing it, the shift began the other way. And people were less concerned about the budget neutrality of it as it was moving money more and more to procedural services. It's really become a political issue now that it's doing the reverse. So, but the reason it's budget neutral is, and this is something Congress has been grappling with even before the fee schedule existed, is they're trying to control the total Part B spend, but they really only control the price. And so as spending keeps going up, they keep looking at constraints on price. And it's a vicious cycle that has not worked. It hasn't worked since '93 when we had volume performance standards, the sustainable growth rate, and that's why we think many of us up here on this panel are in accountable care. We think there is a better way to get to the right sizing of the spend. It's not through squeezing down on the fee schedule.
I appreciate that. One of the policy levers that they've pulled are around advanced primary care management codes, where really they're getting to resource a set of capabilities. And I think that's really important as we think about the transition to value. Do any of you have thoughts on how you're approaching that? I would agree that I think the uptake is likely to be low at the beginning, but I would love to hear your thoughts on APCM.
I mean, from the perspective of like a practice who maybe isn't participating in a MSSP program, this could serve as like a really valuable on-ramp towards scaling up the capabilities that they're going to need to successfully participate in one of these programs. If you're not capable of care coordination, behavioral health integration, you're probably not going to do well in a program like this. So putting some practical financial support to practices who maybe haven't taken the leap yet, I think is, again, we're going back to the word signal, a good signal that CMS is looking to help pave the way for those practices.
I would absolutely agree with that. Katie, for you, for groups working in full risk arrangements, how would you say that the finalized policies help in that transition? Are there any that specifically jump out at you?
Yeah, and I know, again, we'll talk even more about the skin substitutes issue, but we've seen such a proliferation of spend and utilization on skin substitutes. I think there was maybe some commentary on the change in price over time too, where I mean, in 2025, we've seen upwards of $5,000 per square centimeter for some of these solutions, whereas before we were seeing prices much below $1,000 per square centimeter, even lower. And so you can imagine when you are accountable for the total spend in Medicare for a patient who you are not applying wound care, skin substitutes to, but you're on the hook for those costs, your utilization, your MedX becomes wildly unreliable and unpredictable. if you're a small ACO or if you're an ACO with just a couple of patients with very high spend, that can completely undo all of your work. It can wipe you out. It can take you from the black to the red really fast. We have been in a fortunate position with eight ACOs where our patients haven't been targeted as much, and we've still seen a threefold increase from 2024 to 2025. We only have about 10 million in spend, and it's crazy to say only 10 million in spend, but I've heard of patients, single patients, who have cost $10 million for a single ACO. If it's not fraudulent, it's certainly abusive and wasteful, and so the finalization of the skin substitutes payment cap, I think, brings a lot of predictability and a lot of relief to providers from 2026 forward, that these kinds of runaway spend won't happen, at least in this particular category. Now, we're going to see more in other categories as well, and I think there needs to be a broader solution. I would also say one thing that we hope to see built upon this policy change is some way to account for the harm that's already been done in 2024 and 2025. Mara has other members who have been much more harmed and affected than our ACO, so maybe I'll reserve those comments for you. But I would say that is a big policy finalization that helps ensure ACOs can continue to work towards success.
Yeah, it's funny you mentioned that. It's not something I had ever really tracked before in primary care. And when I began reading, and thanks to Mara, I became a lot smarter on the issue. I couldn't believe the dollars that were at stake there. Mara, do you have anything to add to that?
Sure. I would maybe sort of wrap around Katie's comments by saying that we have seen the spend is outrageous and eye-popping, the growth in spend. So for those who haven't followed this issue, $250 million of spend in 2019, $15 billion of spend in 2025. The explosion of spend is very concerning, and then ACOs in many ways left on the hook for that. I would say the more disturbing part is the patient harm. So we have seen from the ACO data patients who were given $3.5 million, $4 million, $5 million of skin substitutes while on hospice in their final months of life, preventable amputations, wounds that have become so infected as to be infested with maggots. So we are talking about really substantial patient harm in addition to the money part. If you haven't followed this, I would urge you to take a look at it because it's a really serious problem, and there is a substantial victory in this rule. There are many organizations that are lobbying and pursuing action in the courts to undo this rule, so we still need your help. I think in many ways, the skin substitute crisis underscores the value of alternative payment models and ACOs, and in so many ways, this is what ACOs were made for, to find fraud, waste, and abuse, and to root it out of the system. And I think that in many ways, the ACOs, including the ones here today, were the canaries in the coal mine saying, hey, we see trends in the data that are really problematic, and we need you, CMS, to be a better partner in fixing the payment, in going back and making sure that ACOs aren't being held accountable for fraud outside of their control, and for stopping these claims from going out the door in the first place. And you've heard Dr. Oz speak about that a fair amount as well. So we're hoping, as Katie said, this is the final rule which caps the payment and changes the way that these products are paid, brings some control to the pricing going forward. We are also asking CMS and CMMI to put some protections in place for ACOs who have seen those single patients in the $10 million, $3 million extreme ranges of spend, and to really ramp up the efforts from a program integrity perspective to stop these things from the source before we get to this situation in the future.
I want to echo, I think Katie started, which is to thank Maura, who was a real leader in this issue, working with CMS. But also, we run ACOs, and we help control Medicare costs, and we help improve care for Medicare beneficiaries. But skin substitutes shows, as Maura was just saying, why we need a strong partner in CMS. Because you get to $15 billion of spend partially through fraud, which we can detect but not do anything about other than report, partly through lax coverage rules, which has been true in this area, which ACOs can't affect coverage rules, partly through perverse payment incentives, and that's what CMS has stepped up here and done a really hard thing and I hope fix the payment rules. And other aspects that are outside the control of the ACOs. But we can work in partnership, as Maura said, help CMS realize where these hotspots are developing, and then together root it out. But what our ACOs are really going to be strong at is improving the care. And so we need CMS to be a partner to handle these outlier situations.
And we want credit for the savings that we're finding.
Fair enough. So accountable care relies on things like chronic disease management, team-based care, care coordination. Are there specific policies in this rule that you feel really acknowledge the importance and support those activities?
Maybe I would start just quickly with acknowledging the work that CMS did on the ambulatory specialty model. I'm certainly no expert in all of the technical elements of the model, but I think, again, signals are important, and ACOs and primary care providers have long been saying that if you're going to control the spend in Medicare, you have to look at specialty, right? We have to pull specialty under the value-based care tent, and I think this is a step in that direction. I think there are a variety of opinions about how the model is constructed based on MIPS, et cetera, et cetera. Certainly we have specialists in our ACOs, part of multi-specialty groups that we would hope as part of a total cost of care model would be exempted. Right now that's not part of the model. But again, the signal is very important that specialty care is on their radar. The model does require that there is a tie back to primary care, which is a huge piece of this. ACOs, particularly those who are maybe on the full risk side of the spectrum, sophisticated, have been doing this work for years, have tried to make inroads, and in some cases and in some markets, you can do that. If you have enough patients, if you have enough providers, market force, you can do this on your own. You're still working around the margins. It's really hard. So this is another area where having CMS's partnership and hopefully ongoing partnership as this continues to develop is really important.
I think to get independent primary care practices to engage in value-based care, first they have to be able to exist. And so by starting to rebuild the foundation of payment for primary care, particularly community-based primary care, is an essential step one before you can even begin talking about accountable care. So by doing the work in that area, they have helping to build the foundation. As I said, I think we're going to see more action next year, and the two challenges in accountable care will be, one, there's a lot of primary care docs who are in ACOs, but there's just as many who are not in ACOs. So we need to talk to them and find out, why are you not in ACOs? And I think part of it is that the model's not finished. Like, these are not early adopters. They want to know that the ACO model is a sustainable, functional way of doing business. And we're most of the way there, but there's a lot of work to be done on benchmarks and on cash flow to get the model there. And then secondly, for those who are in and those who are coming in, how do we get better performance? It has been largely a success, but I know we can do better. Katie mentioned bringing more specialty care into it. And there's a lot of really technical payment rule type stuff to be done around benchmarks and other rules in ACOs that we're going to be, and I know everybody here is going to be engaging with CMS on, with hopefully some serious rulemaking next year.
So we heard Chris talk about loneliness and the need to engage community and understanding the context of care where people are receiving care. And I heard a lot of themes that really support continuity, and we know that primary care, that is part of the magic. I know that there was a provision in there around G2211, which just rolls right off the tongue. It's a very exciting name. But would you like to talk about what that means and how that's going to help promote more community-based primary care?
Yeah, absolutely. So G2211 is an add-on code to account for complexity. And AFP has long been calling for expanded use of this code, particularly the fact that until January 1st, 2026, it couldn't be billed alongside home and residence-based E&M services. So docs making house calls couldn't bill that extra complexity, which is kind of crazy, considering you're making house calls. There's a reason for that, and a lot of times these are the most vulnerable, most isolated patients. So we're going to make sure that we're paying docs the right amount when they're making these house calls. And just to add on to that, something that came to mind is one of the instances where CMS actually reversed course in this final rule was the social determinants of health screening code. They had proposed to remove it, and we had commented asking that they keep it in, and they did. So it's also nice to see that they're listening to comments, they're taking feedback, and they're saying, oh, and this actually aligns with what we're looking for. We're willing to make a correction in the final rule. So I think the two of those combined are going to help address this loneliness problem.
So as we wrap up, I think we also heard that there are some limitations to even their bold actions, that Congress is going to need to be in a position to help pull some of these proposals to their fullest potential. Does anyone have any homework assignments for Congress as those doors start to creak open that we would like to see them take on to really bring some of these policies to their fullest?
We would really love to revive the bipartisan macro work that was happening. I think everybody probably in this room and virtually spent a lot of time thinking through different proposals for stability in the fee schedule, to bring some order to the MIPS program, to reinvigorate incentives for advanced alternative payment models. There was a substantial amount of work done with the Senate Finance Committee on a bipartisan basis. We were starting to get interest from House committees. So on my wish list would be to reinvigorate that work and bring those parties back together to continue that discussion.
I would add maybe two things. The first, I also have to give Mara credit for in her leadership with Accountable for Health, is legislation that would create a permanent full risk ACO program. I think right now part of the challenge for those of us in the full risk ACO world is that we've been operating on demonstration models, pilot programs that are time limited, meant to be time limited in duration. We're sort of nearing the end of one of those right now, and there's not a lot of clarity about what's going to happen next. And so signals are important, predictability is important, sustainability is important for primary care providers who want to do this work, particularly those on the vanguard of the risk spectrum. And so having a permanent option doesn't negate the need to continue testing, right? There's a lot that we can continue. I think, Sean, you named several items that need continued work, but having a permanent home so that in the event there is a lapse or a gap or whatever the case may be, there's a home for those providers is really important to us. And then I would just pick up on maybe a thread that Joe left for us on telehealth. If we had had this panel 45 days ago, it wouldn't be on my list. We've now experienced for the first time the expiration of the Medicare telehealth policies, and let me tell you, it has been rough. I spent a lot more time than I ever thought I would, just trying to explain to payers and providers, et cetera, even those in ACOs, those who have authority to continue doing this work. Nobody was sure. Nobody was confident they were going to be paid. The list goes on, and so I would really love to see a permanent extension of those telehealth flexibilities.
I would echo Mara in that I think we need to signal to primary care doctors who are not in ACOs that this is important, that it's good for them and it's good for their patients. And by signaling some sort of APM bonus that's larger and more immediate. So right now you're getting the more beneficial fee schedule update for work you did 2 years ago. Mm-hmm. That doesn't work. We talked to our doctors.
You paid your bonus 2 years late, Sean.
And even when the APM bonus was bigger and it was delayed, our docs didn't believe they were going to get it. It didn't influence their actions. So make it immediate, make it big, make that a signal. This is the direction you should go in. And the second is, and I think this would be good for doctors and patients, is give the patient something for participating in value-based care. Waive co-payments when they see their ACO-aligned primary care doctor. And we're talking about whether they should waive co-payments for APCM. Why not any primary care service from your doctor who's in an ACO? That's what half the battle of the ACO is, getting the patient in at the right time, and why should finances be a barrier if it's going to save money in the long run and lead to better health?
Well, I'd take what Sean said and go a step further and say waive co-payments for primary care, period. We saw CMS struggling with the legality of that in the context of APCM. Sean granted them the authority that he had to waive co-payments, but we'd like to see Congress do that as well and just kind of take that off their plate. If affordability is the buzzword on the Hill right now, let's make it affordable for patients to go get that preventive care from their primary care provider right now.
I just want to thank you all for being here. I think that's, a lot of times it's easy to get very problem focused, so it was refreshing to talk about a lot of the opportunities that exist. So helping us, yes, Sean?
We are all too busy thanking Mara that we forgot to thank you all in the Academy for the great work you've done. And this doesn't come out of nowhere. I know you've been working in the trenches for years trying to get these sorts of policies. And it's nice, it must feel nice to finally see a payoff and a path forward.
It's exciting to have something positive to talk about, and I think there's a lot of opportunity. And so I just want to thank you all for being here, and I will turn it back over to Sean. Okay, all right, and actually we will just wrap up. Thank you all for joining us today.